Okay, so greetings everyone and welcome to the 59th session of the online Optom learning series. There are a couple of announcements to make. The online Optom learning series or OOLS is very proud and happy to announce that we are now accredited by the Optometry Vietnam team. So we are not only accredited by OCI, Optometry Council of India, IPAO and PSPHOO, but we are also now accredited by the Optometry Vietnam team. So all these future sessions would be accredited by the four international regulatory bodies. Not only that, we are also very privileged to be partnering with SEGI University Online to provide these sessions on the SEGI University Online portal. So just to give you a brief, what is SEGI University Online? SEGI University Online is the online arm of SEGI University that advocates the use of trendy digital tools to make teaching and learning more effective. So it has been there since the year 2010, and besides managing learning platforms, it also provides online courses which are academic programs such as MBA, Bachelor's of Business Management, Bachelor's of Mass Communication, Executive Diploma in Business Administration, and Diploma in Early Childhood Education. These programs are actually targeting the working adults. And today, SEGI University Online also offers massive open online course. So this is where OOLS will be partnering with SEGI University Online to provide all the OOLS videos or seminars or sessions, whatever word you want to use, on their portal. And OOLS will be developing this course on their platform. Not only developing the course, but we are trying to make it more interactive with international certification. So this is still in progress, but when things are ready, we will send out the email and you can go to their portal and take up the courses. There are many other courses as well. So I would recommend during this time, if you could go to SEGI University Online, Google that up, and see what courses do they offer, and wait for OOLS to be seen there very, very soon. Let me introduce to you our speaker for today. So today we have Dr. Arjun Gokani. Dr. Arjun is an ophthalmologist who is trained in glaucoma at the Shankaran Netralaya Eye Hospital in Chennai. He is the head of glaucoma department at the KEM Hospital, and he also practices at the Eye Solutions in Mumbai. He has a vast interest in minimally invasive glaucoma procedures, and he has undergone, I think more than 500 glaucoma surgeries as of today.
I lost count.
Am I right? Sorry.
Yeah, I've lost count actually.
Even you have lost count. Yeah. So yeah. He's more into glaucoma surgery and management of glaucoma. And he has already done one session which was on anti-glaucoma medication on our platform. So if those who have just joined in recently, you can go to our YouTube channel SK Optics and you can view his session on anti-glaucoma medication. And he's been very kind enough to do a series of talk for us in terms of evaluation and glaucoma diagnostic, where today's talk, which is the first of its kind, where Dr. Arjun is going to cover more about the history taking and the basics of intraocular pressure. So welcome, Dr. Arjun. Thank you very much once again. And let me just leave the screen time to you now.
Thank you, Fakhruddin. First of all, I'd just like to say congrats. You're doing a fantastic job. You and the OOLS team are doing an amazing job. I think this is the 59th session, right?
Yes, that's right.
Yeah, that's just amazing. And also getting accredited by all the different countries, now Vietnam also. I think it's a very commendable job that you're doing. So kudos to that, and thanks for having me again. I think it's a great honor to be talking on this platform and teaching all the budding optometrists. As I saw in the poll, there are a lot of optometry students over here. So this talk will particularly be very pertinent to them because it's a complete basics of glaucoma course. And to become a master in anything, I think having a strong basics is very important. Having a strong foundation is extremely important. So this will help them in that. So today I'll be taking patient presentation and history taking, as well as the initial part of IOP measurement or tonometry. And tomorrow I'll continue with tonometry, recent advances, and gonioscopy. So without further ado, let me just start. So before I start talking about history, I just want everyone to focus on this chart. So basically this chart shows us the distribution, global distribution of all the different types of glaucomas that are there in this world. So on the right side of the chart, you have two big pieces of the pie. This blue one is primary angle closure glaucoma. As you can see, it's around 34.7%. And this red pie is primary open angle glaucoma. So basically around 50% of glaucoma, which is basically these two pies, is primary glaucoma. And the other side, if you see the left side, there are all these multiple small pies, which are all your secondary glaucomas: uveitic glaucoma, post-traumatic glaucoma, pseudophakic glaucoma, developmental glaucoma, steroid-induced glaucoma. All those things are also, when you add all of them up cumulatively, it comes to around 50%. So long story short, if you go to see the entire population of glaucoma in the world, half of them will have secondary glaucoma and half will have primary glaucoma. So any patient who comes into your center, into your clinic or your shop, if they have glaucoma, they have a 50-50 chance of having primary or secondary. So anytime we take such a patient's history, we should rule out all the different types of glaucomas because they have an equal chance of having either of them. So basically from this chart, we know that we not one single glaucoma should be ruled out, all of them should be ruled out. So how do we rule them out? Before that, we need to know how the patient presents to us. So a patient, usually when the patient comes to us, the most common complaint that a glaucoma patient has is nothing. He'll just come for a routine checkup, or he is being checked out for something else, and glaucoma is just a coincidental diagnosis in such a patient. So this occult symptom of nothing is the most common presentation of any glaucoma patient. The second most common is a frequent changing of glasses. So that is something that you all will see a lot in your shops or in your clinics or in your hospitals, wherever you all are practicing. Patients will come every 3 to 4 months with a number changing. So these two are known as the occult symptoms, because patient doesn't really know that anything is wrong. He just feels he should get himself checked, and he comes to you, and that's when glaucoma is found. So these are the most common presentations of glaucoma, but then there are the obvious symptoms also. And these patients are usually acute cases, or they had a sudden acute angle closure attack or something like that. So those are these are the ones that are very obvious, and the patient will come to you with a sort of emergency kind of a situation. And those are pain. The patient will complain of a brow ache around the eyebrows, headache of the forehead, and redness of the eyes, as you can see in this image over here of angle closure glaucoma. Even in phacomorphic glaucoma, where the lens is cataractous, you will get redness of the eyes. Patients will complain of halos around light. Patients will have insensitivity to bright lights, photophobia, they'll have glare. So these are the obvious symptoms of glaucoma. So what should we ask the patients when they come? Obviously, we've taken an initial history and we know that they have all those symptoms, but also to confirm. So if the patient comes with no symptoms, but we suspect glaucoma, then we have to ask these particular set of questions. Obviously, if they come with obvious symptoms, we know it's glaucoma, so it's not very difficult to diagnose. But if they come with occult symptoms, then we need to ask leading questions. So first and foremost in that history is the family history. So we should always ask if there are any first order relatives who have glaucoma, because that increases the chance of getting glaucoma by 8 times. And as you can see by this chart, this is a pedigree chart of transmission of glaucoma from generation to generation. There's a multi-gene modality. There's no particular fixed order of inheritance. Like you cannot say it's an autosomal dominant or autosomal recessive. As you can see, the females are giving it to their daughters, they're giving it to their sons also, then males are giving it to their daughters and sons. So it doesn't form any particular pattern. It's a random form of inheritance, and it's due to that multi-gene modality. Multiple genes are involved in this. So a family history is always important because it increases the likelihood of you having it by 8 times. Second thing we ask is any history of drug history. In that, the most important one is steroids. Now, steroids in any form, whether it's an inhaling steroid like in asthma patients, or some steroid cream like for acne, or whether it's oral steroids in patients who have inflammatory diseases, or some systemic steroids have been given, IV or something like that for some kind of neurosurgery or something. Those patients, we should always rule out this form of drug intake, because there is a form of glaucoma called steroid induced glaucoma. So what is steroid induced glaucoma? Basically, there is a particular sect of the population which is more susceptible to steroids, and there is a particular, and the rest of the population is not susceptible. So the people who are susceptible, they are called as steroid responders, and the people who aren't are non-steroid responders. So why are people steroid responders? What makes them steroid responders? So now if we do a microscopy of the cells of the trabecular meshwork, we notice that the nucleus of the cell has these steroid receptors. And there are two types of steroid receptors. One is the beta and one is the alpha. Now, when a steroid attaches in a normal cell, like the one on your left, there is equal distribution of alpha and beta. Now, the job of the beta is to downregulate the alpha activity. So when the steroids attach to the steroid responders, the alpha gets activated and it forms this thing called an extracellular matrix. But now the beta receptors will prevent alpha from getting from manufacturing ECM excessively. So there's a balance between the beta and alpha. Beta is always suppressing alpha from forming this ECM when steroids are attached to it. However, in steroid responders, when the steroid attaches, in steroid responders, firstly, the beta is very low. It's mainly all the alpha receptors are present in the nucleus. Beta receptors are very low. So the balancing act goes away. Now the alphas are completely free to do whatever they want because the beta is not there to check them. So they just go crazy manufacturing ECMs, and this particularly leads to steroid induced glaucoma. Now you'll want to know what is ECM. So extracellular matrix is a jelly-like substance that every cell secretes. And the use of extracellular matrix is it helps in keeping structural integrity of the cells intracellularly and extracellularly also. So if there's a group of cells, it will maintain the structural integrity of all the cells in that group, in that tissue. So extracellular matrix is an important thing. However, when it is excessively created, it forms like a jelly-like layer over the trabecular meshwork and it blocks the outflow of aqueous. Therefore, steroid responders which have higher amount of ECM will have less outflow of aqueous, and there will be an aqueous buildup inside the eye and the pressure will build up subsequently. Second thing we ask is any history of systemic medications. There are patients who have BP problems who take beta blockers. So for them, then we cannot prescribe a beta blocker eye drop because it will be ineffective because they are already taking beta blockers, and in spite of that, the pressure is high. Then there are certain kidney patients who take carbonic anhydrase inhibitors. For them, again, we cannot use Dorzox or Diamox because they are already on these substances and the IOP is still raised in spite of those. So it's important to take systemic medication history also so that we know which AGMs we can prescribe to such a patient. Then the next thing we ask is a drug allergy history. So there is a particular category of drugs which many patients are allergic to. They're called sulfa drugs. You all have all heard of this. So we must ask a patient whether he is allergic to sulfa drugs, because a very important category of glaucoma medications, the carbonic anhydrase inhibitors, are also sulfa drugs. And in patients who have this allergy, we cannot prescribe carbonic anhydrase inhibitors. A second group of drugs is a monoamine oxidase allergy. So for these patients, we cannot prescribe alpha-2 agonists as they are also monoamine oxidase medications. So we should always ask a patient if he is allergic to any particular category of drugs, and a patient who has allergy will tell you specifically which drugs he's allergic to, whether he's a sulfur drug allergy patient or a monoamine oxidase allergy patient. So it's important to ask a allergy history. Third thing we ask is a lifestyle history. Now there are patients who have habit, not only patients, lot of people, they have this habit of waking up in the morning and drinking excessive amounts of water in a short span of time, like say 1 liter of water in 5 to 10 minutes, because they feel that it cleanses their body. Now, although it might cleanse their body, what it does is, because there is a fluid overload inside our body, there is also a fluid overload on the eyeball, and this causes a rise in the IOP. Therefore, we must always ask whether any patients are into such water drinking habits. A second one is yoga. Any patients who perform yoga where they are constantly in postures where the head is below the waist, like for example on the left side, I'm sorry, I don't know the names of these asanas, I'm not a yogic myself, but you can get the idea. Anytime the head is below the waist, it causes the blood flow to increase to the head and causes a venous pressure rise in the head area. Now this venous pressure rise will cause a episcleral venous pressure to go high, and indirectly cause a rise in IOP. So any yoga also, suppose someone is performing, master level yoga where they're doing headstands or they're doing back bends like this, then those are also predisposing factors to glaucoma. So we must always ask whether patients are performing yoga in these postures. The fourth thing we take is the systemic illness history. So we must always know whether the patient is a diabetic, because diabetes increases the chances of a POAG, whether the patient has any rheumatological joint disorders or any rheumatological disorders in the rest of the body, because these patients are predisposed to having uveitis, and uveitis is also a cause of glaucoma or secondary angle closure glaucoma. So rheumatological diseases and diabetes mellitus is very important to rule out. Then a very important thing for glaucoma is the ocular history. So a patient may come to you with, many decades ago he might have had a trauma in his eye. Now that trauma is healed, the pain of the trauma is gone, the damage that the trauma did will remain forever. So what does trauma do that causes glaucoma? As you can see in this image over here, the thin brown band is your trabecular meshwork. Below that there is a white band which is the scleral spur. Now below that is the ciliary body band, which should also be somewhere similar in thickness to the trabecular meshwork. However, in this case you can see it's so thick. So this is a classical case of angle recession glaucoma, wherein the muscles of the ciliary body get disinserted from each other and cause a widening of the ciliary body band. Now when you see such a broad ciliary body band in a patient who gives you a history of trauma, it is a classic angle recession glaucoma, and such patients have glaucoma for life, which is mostly treated only through surgery because they are refractive to medications also. So trauma history is very important, particularly blunt force trauma to the eyes. Second thing we ask in ocular history is surgery. Any history of any corneal transplants, any recent cataract surgery, any recent retinal surgery. So how do these surgeries cause a rise in IOP and hence glaucoma? So a corneal transplant like this one will cause dysgenesis and deformation of the trabecular meshwork, and that there will be a reduction in the outflow of aqueous in corneal transplants. In cases where there's a recent cataract surgery, there can always be a uveitic component of glaucoma or a visco-retention glaucoma, where visco is retained in the eye and it causes a spike in the IOP. And in retinal detachment surgeries, because we are putting oil and gas inside the eye, it can cause a rise in IOP for a very long term, which can lead to glaucomatous damage in the long run. Third thing we ask is any history of infections or inflammations. So in this image, this is an image of herpetic keratouveitis. So herpetic keratouveitis is notorious for causing glaucoma, and that too very high spikes in IOP, along with glaucoma which is refractive to medication. So such patients, we should always ask the history, and many times the IOP remains high in spite of the infection going away and healing. So we should always keep patients with herpes under our close monitoring and check their IOPs periodically and treat them as soon as their IOP goes up. And inflammations are important because they can either lead to acute glaucoma due to the inflammation itself, due to the cells blocking the trabecular meshwork, or in the long run they can cause PAS, which is peripheral anterior synechia, where the iris gets stuck to the trabecular meshwork and it blocks the trabecular meshwork from allowing aqueous to flow out. So these three things in ocular history are very important to ask. Now, as I had mentioned in my last talk also, many of you all might not have been there, so I'll just explain this again. Normal tension glaucoma is basically that type of glaucoma where the pressure is normal, but the ocular perfusion pressure and the IOP balance is out of the normal range. So for any optic nerve to remain healthy and the nerve fiber layer to remain healthy, there should be a balance between these two. The ocular perfusion pressure should always be higher than the IOP. So when that happens, the blood flows to the optic nerve easily. However, when the IOP is higher than the ocular perfusion pressure, there is less blood flowing to the optic nerve and there is damage to the retinal nerve fiber layer and the optic nerve. But in normal tension glaucoma, the IOP is normal, but the ocular perfusion pressure is so low that in spite of a normal IOP, blood is not reaching the optic nerve head. Therefore, these patients still have optic nerve damage and we still need to reduce the IOP from a normal level to a even more lower normal, as we would say, a lower normal, where it would be somewhere between 10 to 12. So in normal tension glaucoma, the main culprit is a reduction in the ocular perfusion pressure. So what questions can we ask to rule out normal tension glaucoma? Basically, we ask the patient whether he's had any attacks of low BP or he takes BP medication at night, and because of that, when he's sleeping, the blood pressure falls low. So a low BP will cause a drop in ocular perfusion pressure also, and hence it will cause normal tension glaucoma. Second thing we ask is we ask for any fainting spells, because that also people usually have fainting or syncopal attacks when less blood is flowing to the head. And if less blood is flowing to the head means less blood is flowing to the eyes also, and the ocular perfusion pressure is low. Then we take a history of any episodes of blood loss, whether there was any accident or any major surgery was done in the past, because this will also reduce the perfusion pressure. And lastly, we take a history and ask the patient if he or she has suffered anemia ever or is suffering anemia. So what happens in anemia is, even if the ocular perfusion pressure is normal, because the basic nourishment carrying capacity of the blood is low, less nourishment is going to the optic nerve head, and there is normal tension glaucoma happening over there. So all these four things we must ask when we want to rule out a case of normal tension glaucoma. So yeah, this is the end of my first part. So this is just a little quote from Lion King, a very epic movie, where they say that you can either run away from your past or you can learn from your past. So same way we can learn from our patient's history and we should not run away from it. So now I'll move on to IOP measurement, the first part. So in this part, I'll be discussing all the influencing factors and the methods of measurement of IOP. And in the methods of measurement, I'll be only talking about the basic instruments that we use. I'll be talking about recent advances in tomorrow's lecture. So let's start with the influencing factors. So what are the factors that raise the IOP? So one of the main factors that raises the IOP is anything that causes a raised episcleral venous pressure. So raised episcleral venous pressure will indirectly cause a spike in IOP. Now, what are the things that cause a raised episcleral venous pressure? Many times a patient will come to you wearing formal suit or formal shirt with the collar buttoned up, or he'll be wearing a tie. Such patients usually have a tight collar. Now, what happens in a tight collar is, because this collar is tight, the blood from the head is not allowed to flow to the rest of the body and it just accumulates in the head and neck region. This causes a rise in the venous pressure of the head and neck region, hence causes a rise in the episcleral venous pressure, and hence causes a rise in the IOP. It's like a domino effect. So one thing goes up, the other thing goes up, the third thing goes up. So a tight collar, we should always ask a patient to loosen their tie, to open the collar button, then check the IOP. Second is, many times the patient is apprehensive, so they'll be holding their breath when they're on the slit lamp, and they're nervous that something might be touching their eyes or the air puff will hit their eyes, so they'll hold their breath. But that also causes a rise in the episcleral venous pressure and hence the IOP. The third thing is an orbital tumor. Now, orbital tumors also, when they sitting in the orbit, when they compress on the veins of the eyes, it causes a backward rise in the episcleral venous pressure, and hence causes a rise in the IOP. So we must always notice any corkscrew-like vessels, any large veins, dilated veins in the eyes. One eye is either more is protruding more than the other, which is called proptosis. Or we should notice whether there's a big bulky swelling of the eyes like this one. Then we should keep our antenna up for any kind of orbital tumor and advise the patient to get a CT scan done, or rather meet a oculoplastic surgeon who can take care of the rest of the management. Now this slide is important for those of y'all who do examination under anesthesia. So a lot of y'all must be working in hospitals where y'all have to do the examination under anesthesia for children and uncooperative adults also. So for that, I'd like to explain these two concepts, that during the intubation of a patient who is undergoing general anesthesia, there is a spike in the episcleral venous pressure, and therefore whatever pressure we measure after intubation is a falsely high IOP. So our aim is to measure the IOP before intubation in such patients. So we must always wait for the patient to be sedated, and before the intubation happens, quickly check the IOP and then let the intubation happen, because otherwise we'll be measuring a high IOP. Secondly, when the patient is on the operating table or in a lying down position in your hospital ward also, we must always make sure that the head is not lower than the feet. This is known as a Trendelenburg position. We must always make sure that the head is slightly elevated or at the same level of the feet, which is known as a reverse Trendelenburg position, because this also causes a accumulation of blood in the head and neck region, and then that domino effect follows. The second reason for raised pressure of a patient in your falsely raised pressure of a patient in your OPD would be if a patient who is anxious and is not allowing you to touch some probe or some instrument on the eyes, if they're squeezing the eyelids like this, it will cause compression on the eyeball and a rise in IOP. And in children who usually are not cooperative for IOP measurement, they're usually crying. And whilst crying also, the eyelids are squeezed and it's pressing on the eyeball, causing a rise in the IOP. So pressure on the eyes by crying or squeezing of the eyelids is also something that we need to avoid when we're measuring the IOP. Now, factors that lower the IOP. There's aerobic exercises are known to lower the IOP. So anytime a patient has just come from who's known to exercise, we always ask them to come after a couple of hours of exercise so that we can check their IOP. Then anesthetic drugs like propofol, they also cause a reduction in IOP. Therefore, again, during examination under anesthesia, before the propofol is given and just after the sedation is given is the best time to check the IOP. Otherwise, we'll be measuring a falsely low IOP. Then pregnant ladies also have a lower IOP than normal. And there are these addictions that no one would recommend, but if someone has taken this, then there will be a reduction in IOP for a short span of time. But that doesn't mean that we can use any of these for glaucoma management. Then, now I'll talk about tonometry. The classification of tonometry is described in this slide. Basically, there are two types of tonometry. One is direct tonometry and one is indirect tonometry. Now, under direct tonometry, there is something called as manometry, which is theoretically the most accurate way of checking a patient's pressure. What is manometry? It's a theoretical concept and it was done experimentally in humans and animals, where they inserted a probe inside the eye, and this probe from inside the eye was measuring the actual true pressure of the eyeball from inside. But because it's such an invasive thing, just to measure IOP, we're not going to insert a probe in the vitreous cavity or in the anterior chamber. It's never been done in normal practice. However, it's something to know for just the theoretical purpose. Now, indirect tonometry is what we are all very familiar with and very comfortable with. Now, in that, there is contact tonometry and there is non-contact tonometry. Contact tonometry is also subdivided into two types, which is indentation and applanation. In indentation, there is a Schiot's tonometry, which many of you all might not use, but it is still commonly used in rural camps and in places which don't have good facilities for checking IOP. And there is applanation, which most of you all are very familiar with. in which there's Goldman's, there's Perkins, and there's Tonopen. And then there is non-contact tonometry, which is air puff tonometry, again very commonly used by all of you all. Now I'll be describing all these types of tonometry in brief in the following slides. So we'll start with indentation tonometry. Now the principle of indentation tonometry is we place a needle on top of the eye and we see how much the needle can indent the eye. Now it's quite obvious if we think of, you know, common sense, if we think of a rubber ball also, if the rubber ball has a lot of air in it, if a plastic ball, sorry, not a rubber ball, if a plastic ball has a lot of air in it and it's tightly filled, then we won't be able to compress it. We won't be able to indent it with our fingers. However, if it's deflated, if it doesn't have enough air, we put our finger and it will go right through and through and it will come back also. So the same principle is with the eyeball. You can consider the eyeball to be like an inflated balloon. Now, if the balloon is tightly filled, this pin, this tonometer pin will not indent it and it will not sink all the way in. Whereas if the IOP is low, which means that it's like a deflated balloon, then it will sink all the way in. Now, how do we measure the IOP with just this fact? So now if you look at this Schiot's tonometer over here, it's got multiple components. This is the foot plate which rests on the cornea, and this is the pin which is protruding out of the foot plate. Then there is a plunger over here on top of which we put these weights. These weights sit on the plunger which help push this pin into the cornea. Then on top of the plunger, there is a lever arm. So the more the pin goes into the cornea, the more this lever arm comes down and the more this needle moves to the right side. This is just basic mechanics. If you just think of it logically, this goes down, and the needle goes to the right. So the softer the eye, the more the pin goes in, the more this lever arm moves and the more this needle moves. So if you do transitive property, the more this needle moves, the lower is the IOP, basically. And the less this needle moves, the more is the IOP. So it's inversely proportional to the needle movement. Now, if you see the markings also over here, it's 0 to 20. So the higher the value that the needle is showing, the lower the IOP, and the lesser the value the needle is showing, the more the IOP. Now, you don't have to use your brains too much about all this. There is a conversion chart that comes with every Schiot's tonometer instrument, and many of you all are familiar with this conversion chart. You don't have to mug it up or anything. It's always in front of you. You just have to correlate the numbers with the IOP. But the basic principle is that the more this pin gets indented into the cornea, the lower is the IOP. So now what are the sources of errors of Schiot's tonometry? The first thing is ocular rigidity. Now, in spite of having a high or low IOP, if the cornea or the sclera is less rigid, the pin will easily go through and through, and it will indent more than it should have in a normal person's eye. So scleral rigidity and corneal rigidity are important sources of errors in such patients. Now, patients with high myopia have thin corneas and thin scleras. So no matter how high the IOP, it will still indent more than a normal person's eyes, because the cornea, the point of resistance is only very thin. And secondly, in children also there is a low scleral rigidity, which is why the pin will indent more. So in such patients, you'll always measure a falsely low IOP. Then corneal thickness. Again, thicker corneas will show falsely high IOP because they'll give a big resistance to indentation. And thinner corneas will show a lower IOP because thin corneas will give less resistance to indentation. Now we move to Applanation tonometry. So Applanation tonometry, the basic principle of Applanation tonometry is your Imbert-Fix law. Now Imbert-Fix law basically says that pressure inside a perfectly round, dry, thin-walled sphere is equal to the force that is required to applanate or flatten a particular fixed surface area of that sphere. So basically, in simpler terms, it's pressure inside that sphere is equal to the force divided by the area that force flattens. Now, Imbert-Fix law says that it's used only for a perfect sphere which is dry and thin. But the eye is not a perfect sphere. It's not dry and it's not thin because the corneal thickness in everyone varies. So there are some extra forces that come into play which are a hindrance to us measuring the IOP. Now, when we're measuring IOP, we are only interested in this green arrow and this red big arrow. The red big arrow represents IOP. So that is pushing the probe away from the eyeball, and the force with which we're applanating, which is the tonometer force, is the force that is going towards the eyeball. But there are these small green and red arrows which represent forces that we don't want to interfere in our IOP measurement. One is the attraction of the tear meniscus of the probe towards the eyeball due to surface tension interferes with the IOP measurement, and also the corneal resistance, the basic rigidity of the cornea also resists the probe from applanating the cornea. So we need to make these two useless forces negate each other. So now how do we do that? So scientists have proven that if we applanate a fixed area of 3.06 millimeters square, this is a number you just have to remember. How they got to that number, only they know that. So 3.06 millimeters square is that perfect magical number where these two forces negate each other and only these two forces, the big arrows, come into play. And that is the point when our accuracy of measuring IOP is the best. But now how do we know whether we are measuring 3.06 millimeters square? We don't have any compass or protractor to help us measure that surface area. So there is a special design of this prism, which I'll explain in the next slide. Just before that, I'll show you the technique. Basically, this is a slit lamp mounted Applanation Tonometry instrument. This is the Goldman's Applanation. This is the prism holder. This is the prism, and under the blue filter, we touch this prism to the cornea and we applanate the cornea by turning this dial. So this dial helps us in pushing the probe forward. That is what the green arrow was in the previous slide, the probe force. And the eyeball pressure, the IOP, is counteracting this pressure. So we rotate this dial and this prism moves forward and it flattens the cornea, and then we have to take a reading of what the pressure would be. So now coming back to 3.06 millimeters square, how do we get that magic number? Before that, I want you to see this video. So when we applanate the cornea, this is what it looks like. So I've just used a balloon and a teacup, but this is basically what it looks like. So we've dyed the eye with this blue dye, with the fluorescein dye, and as we push the probe towards the prism towards the eyeball, the flattening area keeps increasing. Now what the manufacturers of this prism have done, they've split the prism into two halves and they've laterally deviated the two circles. So basically what I've done to show you is you cut this image into half and you laterally deviate both of them sideways to a point where, and then we rotate the dial to a point where the inner meniscus of each of the semicircles, they are touching. Like here you can see the inner meniscus is touching. Here also the inner meniscus is touching. So when the inner meniscus of these two semicircles touch, that is the point when we have hit the magical number of 3.06 millimeters square. And that is the point which on the dial we read the pressure, and that is the pressure of the eyeball. So if the inner meniscus are touching at this point, which is 19 over here, which is 1.9 over here, you multiply that by 10 and that's the pressure of the eye. So another thing is that whatever the value is on this dial, you multiply that by 10 and that is your pressure in millimeters of mercury. So I hope you all have understood that part. So basically, just to reiterate, I'll just say that we have to make sure that the two inner menisci are touching, because that's when that perfect surface area has been applanated, and then we read the number on the dial and multiply that by 10. Now, what are the sources of errors in Goldman's Applanation Tonometry? The first is the corneal thickness. In thick corneas, you will get a false high IOP. In thin corneas, you get a false low IOP. This is a rule of thumb. In most IOP measurements, this is a rule of thumb. Thick corneas, high IOP, thin corneas, low IOP. So when I say thick corneas, I mean something which is above 580 nanometers. And when I say thin, it's something below 450 nanometers. Then decentered applanation also. Sometimes the patient is looking up or looking down and you're trying to applanate, and instead of getting the center of the cornea, you're applanating the periphery of the cornea. Now the periphery of the cornea being thicker, you will always be measuring a falsely high IOP anytime you have a decentered applanation. And a decentered applanation will look something like this. There will be Myers which are asymmetrical. The lower one, suppose the patient is looking up, then there will be a decentered, there will be a higher, the upper meniscus will be bigger than the lower meniscus. And if the patient is looking down, then the lower meniscus will be bigger than the upper meniscus. The upper semicircle. So anytime you have a decentered applanation, you are measuring a falsely higher IOP. So you ask the patient to center their eyes. Astigmatism. Now, according to Imbert-Fick's law, we are supposed to applanate a spherical structure, a sphere. But in astigmatism, the cornea, in severe astigmatism, the cornea is more of a cylinder. So this also results in errors. So now how do we negate the astigmatism and measure the IOP in the most astigmatically neutral position? For that, we have to find out which is the negative axis of the astigmatism and align our prism to the red mark. The axis has to be aligned to this red mark. So this red mark is basically 43 degrees away from the white mark. So if we offset the axis of the negative axis by 43 degrees, it is known to be the most astigmatically neutral position to check IOP. So long story short, whatever the negative axis is, align it to the red mark over here. The numbers, the axis numbers, the degrees are over here. You align that to this red mark. So automatically your prism is offset by 43 degrees because these two are 43 degrees apart, and you measure the IOP in that position. So that takes care of astigmatism. Then staining. If we stain too much, if we overstain the patient, you'll get very thick Myers, and that will cause a falsely high IOP measurement. And vice versa, when we have less stain in the eyeball, you'll get thin Myers, and that will cause a falsely low IOP. This causes a high IOP and a low IOP of somewhere in the range of 3 to 5 millimeters of mercury. It doesn't cause excessively falsely high or falsely low IOP, but yet for the sake of accuracy, it's better to adequately stain the eyeball with fluorescein. Now some of the examples. So this is a Perkins handheld tonometer. This is a Goldman's Applanation tonometer, which I showed you. And this is a TonoPen. A lot of y'all are familiar with these instruments. Y'all have used it. But just for the people who haven't seen what they look like, this is again to reiterate, this is Perkins, this is Goldman's, and this is TonoPen. Perkins, you can see the prism is over here. It's a handheld device. And it's very easy to use in people who are lying down or children, etc. TonoPen, the probe is at the tip. We just have to touch this tip to the cornea and it measures the IOP. This is useful in patients who have corneal scars and corneal opacities. And Goldman's is the gold standard. This is slit lamp mounted, and I've been describing them in my previous slides. Now the last one for today is non-contact tonometry. Now, what is the principle of non-contact tonometry? Before that, I wanted to explain that the cornea, because of its convex shape, when light is thrown on the cornea, it acts as a convex mirror. And as we all know, a convex mirror, when parallel light falls on a convex mirror, it diverges off. The reflected lights are divergent and they get scattered in multiple directions. So in this instrument, we use the same principle of reflection of light on the cornea. Basically, there is a light source which throws light onto the cornea, and there's a collimation detector on the other side which catches the reflected light. Now in a normal cornea, this light is thrown on the cornea and divergent light is moving all over, and this collimation detector doesn't catch too many light rays because they have been thrown in many different directions. However, when we flatten the cornea, it becomes a plane mirror, and a plane mirror, we know that the reflected light of a plane mirror is also parallel. So all the light that is going on the cornea is now parallelly being reflected and it's being caught by the collimation detector. So this detector is catching a very bright beam of light, and at that point, we know when the detector is catching this brightest beam of light, we know that the cornea is flattened, and the machine detects the pressure required to flatten this cornea at the point when the detector is catching the brightest beam of light. So the minute the detector catches the brightest beam of light, the machine measures the pressure that is used, and that is the corresponding intraocular pressure. And to flatten the cornea, air jet is thrown on the cornea in variable force. So in the beginning, the air jet is a little, and this all happens in a split second. So the air jet, the force is less, then slowly it increases to a point when the cornea flattens, the detector catches the parallel light and everything stops. And the pressure is measured at that point. Now the technique of air puff tonometry is, it's a table mounted device like this. It could be a handheld device also. So if it's a table mounted device, then pretty similar to how we mount the patient's head in an auto refractometer, we do the same thing. The air puff goes and hits the eye and the pressure values come on this monitor over here. This is the handheld and this is the table mounted device. The sources of error, again, as per our rule of thumb, thick corneas falsely high, thin corneas falsely low. And the error which is caused in this machine is more magnified due to the corneal thickness or thinness. What I mean to say is, if a cornea is thick, the air puff will show a more false high IOP than any of the other IOP measuring instruments. So the error is more in air puff than it is in any other instrument with respect to corneal thickness. Yeah, that's about it for today, and we'll continue tomorrow with the newer techniques of measuring IOP and gonioscopy. So yeah, I'd love to take some questions now if anyone has.
Sure. Okay, Dr. Arjun. Thank you very much for that very comprehensive talk.
Thanks.
And the first question is, if the ocular perfusion pressure is high and the IOP is normal, can it also lead to normal tension glaucoma?
No, it won't lead to normal tension glaucoma, but such patients are basically patients who have hypertension. So it might lead to hypertensive retinopathy, but blood will still flow to the nerve fiber layer and the optic nerve, and glaucoma won't occur. But if the perfusion pressure is abnormally high, I don't mean to say high with respect to the IOP, if it is abnormally high, then the patient should get themselves treated for systemic hypertension, because then they are susceptible to things like central retinal vein occlusions, hemorrhages in the eyes, and other things, but not glaucoma.
Okay.
Yeah.
The next question is about corkscrew vessels and feeder vessels. Are they same?
So feeder vessels are with respect to any kind of a tumor or a ocular surface neoplasia, where the vessel is feeding into the tumor and is nourishing the tumor, but it has nothing to do with corkscrew vessels. So why is it called corkscrew vessels? I'll just explain. So when there is a tumor sitting behind the eyeball, it's compressing the veins of the eyeball, and due to which the veins, anytime, as we know, even when we take a garden hose or a pipe and we press the pipe, the part of the pipe before the part we are pressing will start slowly inflating, because the water pressure in that is building up. So the same goes with corkscrew vessels also. Just consider it to be like a garden hose, and behind the eyeball someone has pressed on the veins, and because of which all the blood is now accumulating in the veins of the eyeballs, and they have become dilated and squiggly, and those are known as corkscrew vessels. So corkscrew vessels are classical in cases where there's a tumor sitting somewhere behind the eyeball, pressing on the veins of the eyeball. But it's not the same as feeder vessels.
Okay. And the next question is, in which type of glaucoma is the phasing test required? And in terms of diagnosing and treating those type of glaucoma, what will it lead to, results which is mistreating?
I'm not very familiar with what a phasing test is, but if he means phasing of anti-glaucoma medications, what is the second part? Diagnosing, treating the glaucoma directly without phasing test. So if it means phasing test, if it means the phasing of anti-glaucoma medications, how I do it is I usually start with the most basic anti-glaucoma medication. I see whether the IOP is under control, and then slowly, if it's not under control, I'll increase by one or more anti-glaucoma medications slowly. And also I'll keep a close monitor on the patient's perimetry and OCTs. So basically it's a combination of all these things that goes into monitoring a patient of glaucoma.
Okay.
Yeah.
Okay, great. When it comes to the Shiot's tonometry, will Shiot's compensate for the corneal pachymetry as the applanation would probably do?
So the Shiots, it also is susceptible to errors due to corneal pachymetry, and it is more susceptible than the applanation. For example, a thicker cornea will cause more error in Shiots than in applanation. So with comparison to applanation, a Shiots will not compensate, and applanation also doesn't 100% compensate for pachymetry. However, it is more accurate in cases of thick or thin corneas. So it best compensates for pachymetry but doesn't completely compensate, and Shiots doesn't compensate as well as applanation.
Okay, great. And which is the true scale we must follow for IOP correction? Somebody is asking about if you are aware of any correlation of corneal
So
thickness.
see, there are various charts and things like that. Various formulas are also there. None of them are proven yet, but every doctor has his own set of rules. So what I follow is beyond between 450 and 500. I will sorry between 450 and 580. I will manage the patient normally. I'll consider the patient's pachymetry to be normal, and I'll only reduce the IOP if it's out of range, if it's above 22. After 580, every 25 microns, I will consider there to be a 1 or 2 millimeters of IOP, falsely high IOP. Means I'll correct the IOP by 1 or 2 millimeters.
Okay.
So basically, after every 25 micrometer step, I'll correct by 1 millimeter or something like that of mercury. But it's all very subjective. So sometimes you might have a thick cornea with a raised IOP, but the optic nerve is completely normal. So before I start any treatment, no, I'll call the patient every month, and I'll notice whether there is any sort of signs that are helping me to diagnose glaucoma better. If I don't find anything, I'll just continuously observe the patient. If the IOP is above 27, 28, I'll start with 1 AGM and I'll bring it down to 22, 23. Any IOP that's above 28, I'll always treat, no matter how thick the cornea. Yeah.
And a couple of more questions. Is there any
Sure.
particular astigmatism value? When you are talking about the Goldman Applanation tonometry, would we consider, if it is more than 2, we must rotate the probe, or is there any specific value of
So
astigmatism?
there is no particular value, but when you're doing the applanation, what you should be seeing is 2 perfect semicircles. The minute you start seeing abnormally long or abnormally flat semicircles, that means you're measuring a cylinder. You're not measuring a sphere. So when you see that, no, that's when you change your axis of your prism to the red mark. You change the negative axis, align it with the red mark. So there is no numerical value, but when you start seeing subjectively that the mayas have become distorted, you make that correction.
You make that correction. Okay.
Yeah.
And there are 2 parts of the question. Probably we'll take one by one.
Yeah.
Intracranial venous pressure and episcleral venous pressure the same?
So intracranial venous pressure and episcleral venous pressure are not the same, because intracranial venous pressure, it has an effect on the episcleral venous pressure. So what is episcleral venous pressure? It is the venous pressure around the Schlemm's canal. So the veins around the Schlemm's canal, their pressure is known as the episcleral venous pressure, and intracranial venous pressure is the pressure in the veins inside the cranium. But intracranial venous pressure has a direct relationship to the episcleral venous pressure. As I mentioned, that domino effect happens when there's a raised intracranial venous pressure. There's also a raised the episcleral venous pressure and a raised IOP.
I see. Yeah.
So they are not the same thing, but they are connected. And I don't know whether they mean intracranial venous pressure or just intracranial pressure, because intracranial pressure is different from intracranial venous pressure also. Intracranial pressure is a rise in the pressure of the CSF pressure inside the brain. And such patients will have papilledema. If you look at the disc will look swollen if they have a raised intracranial pressure. The second part is
the importance of ocular rigidity or scleral rigidity when it comes to IOP measurement.
Yeah, so scleral rigidity and ocular rigidity plays a role in all the forms of IOP measurement. The
Mhm.
lower the scleral rigidity, the more the falsely low the IOP is, and the higher the scleral rigidity, the falsely high the IOP we measure. This I'll be covering tomorrow in
Oh,
something called dynamic contour tonometry. Just to give a little spoiler of tomorrow's talk, I'll be mentioning this also.
okay, fine. So we'll keep
Yeah,
that detailed
yeah,
explanation for tomorrow.
yeah.
Okay. And is there any difference in terms of IOP with respect to various devices? I mean, your experience, probably you can share on which device.
So my favorite way of measuring is applanation, usually by Goldman's or Perkins. Sometimes I use a rebound tonometer, which I'll be talking about tomorrow. I rarely use a Shiotz because Shiotz will always give me extreme of values. It will either give me a very high or a very low value, but it's a good screening device. And a tono pen also I like, but I'll use it very rarely in patients who have, corneal disease or some corneal scar or something. But most of these devices, the ones I mentioned, except for Shiotz, they give a fairly accurate IOP, and it's usually within a range. Means if the patient's other ocular parameters are the same or
Mhm.
normal, the IOP measured by all these devices is usually it correlates. But if there is an abnormality in the patient's parameters, like a thick cornea or a thin cornea or excessive rigidity, then there will be variability amongst all these devices. But in the variability also, Goldman's applanation is the least variable. That's why it's my favorite instrument. It might take some time to measure the patient's eye pressure, but it's extremely accurate and it's very reliable.
I think when it comes to managing those patients, you would definitely need a true IOP value, and
Yes,
it does
absolutely.
that work for us. Yeah,
Exactly. I
yeah,
mean, no, air puff tonometry and rebound and Shiotz and all are good screening tools.
screening tools.
But the
Yeah.
minute you get someone who has a abnormal pressure, reconfirm it on a Goldman's.
Alright. Okay. And just coming back to the question about phasing test, I
Yeah.
just got some idea about that.
Uh-huh.
Phasing test is usually measuring the IOP during different times of the day to check
Oh,
for
so
any diurnal
so that's
variation.
diurnal variation test
Yeah. Yes.
or office diurnal variation test. So
Yeah.
it is very important. So one of the ways of measuring normal tension glaucoma is, I mean, not measuring, not diagnosing. Yeah, so one of the ways of diagnosing normal tension glaucoma is by doing a diurnal variation test. So what is a diurnal variation test? Basically, we have to measure the patient's eye pressure every 2 hours for 24 hours and see whether there have been any spikes in the IOP throughout the day. Because what could be happening is the patient comes to you during a time when the IOP is normal, and we diagnose the patient as a normal tension glaucoma because the patient has glaucoma, the optic disc is cupped and the fields are defective, but the pressure is normal, and we say that is normal tension glaucoma. But then the patient goes home and at night he has a big spike in the IOP, and that is the actual cause of uh, the glaucoma happening. So for such patients, before we diagnose them with normal tension glaucoma, we do something called a DVT. So we measure the IOP for 24 hours every 2 hours, and if we find there are some spikes, then we'll diagnose them as normal, means raised IOP glaucomas, either primary open angle or whatever, secondary causes, whatever. But if there are no spikes, if the pressure remains normal throughout the 24 hours, then we can clearly say this is a normal tension glaucoma. Now, what it's very difficult to measure someone's IOP for 24 hours unless you have a hospital setup, you have residents who are on call throughout the night, and then you have to wake up the patient also every 2 hours. So, what we do is we do something called a office diurnal variation test, where the patient comes to your clinic at 8 o'clock in the morning and stays till closing time, and you check the pressure in that span of time every 2 hours, and it's fairly accurate and it's comparable to the 24-hour DVT. So it is a very important test, and I do it for most of my patients who I suspect with normal tension glaucoma.
Okay. So that
Thanks for
was,
that question, by the way.
yeah,
That was a
that
good
was the
question.
phasing test. I mean, that probably some different terms used
I
around the
think some countries use different terms for different things. Here, it's commonly known as DVT
DVT. Yeah.
or office DVT.
Okay, and but normally I think that the IOP is more stable in the afternoon. Do you
Yeah,
normally
yeah.
prefer that as well,
So it's
or?
like a double hump, right? So morning there'll be a spike, then evening again there'll be a spike, afternoon there'll be a lull. But in glaucoma patients, no, you'll notice that the IOP remains constantly high throughout the day. In
Okay.
classical glaucoma patients, there are some patients who have these excessive spikes in the day, and those patients get diagnosed as NTG,
Hmm.
but they have these spikes. But once you reach an advanced stage of glaucoma, no, if it's not normal tension, if it's just a general glaucoma, then the pressure remains high throughout the day. Then those spikes get flattened, basically.
So, would you recommend doing DVT for, I mean, suspect of normal tension glaucoma or
Always,
always?
always, yeah,
Okay, I think we have taken most of the questions which are relevant for today, and yeah, we do have session tomorrow as well,
yeah.
where Sir is going to cover more about IOP measurements and the recent advancements, and also will be touching upon gonioscopy, which is also one of the very important diagnostic tests which we can perform as optometrists as well. So tune in tomorrow, same time, and we would be taking up the remaining questions which are relevant to tomorrow's session. And see you all again tomorrow. Thank you very much.
Thanks.
Thank you, Dr. Arjun, again for
Thank
taking up
you.
your time.
Thank you for
We
having me.
are,
See you tomorrow.
yes, surely. We are sharing the feedback form cum certificate